Okay, we're going to go ahead and get started with our first session today. So thanks for joining us. I'm Tim Anderson, one of the biopharmaceutical analysts at Bank of America, and this is a 40-minute chat, fireside chat on emerging treatments for cardiovascular disease, where, in general, there's been lots of progress over the decades. There's still lots of unmet medical need. There's a lot of exciting stuff going on in development in terms of new products and that sort of thing. And room for improvement and additional innovation. I'm joined on stage by one of my Bank of America colleagues, Tazeen, Ahmad, who covers some of the biotech names, and together we'll be talking with four of Mass General Brigham's finest in this area. So we've got Callum McRae, who's Vice Chair for Scientific Innovation, Professor of Medicine at Harvard Medical School, and an expert member of the Brigham's Cardiovascular Genetics Program. We've got Dr. Aaron Bahula, critical care cardiologist, associate physician in cardiovascular medicine at the Brigham, and assistant professor at Harvard Medical School. She's also an investigator in the TIMI study group. We have Dr. Pradeep Natarajan, who's director of preventive cardiology, also endowed chair in vascular medicine, associate professor of medicine at Harvard Medical School, associate member of the Broad Institute. And then Dr. Brian Bergmark, associate physician in interventional cardiology, also an instructor of medicine at Harvard Medical School, and also an investigator in the TIMI study group. It's a lot of bio there. We're going to do speed rounds. Essentially, we're going to cover lots of different categories, really by mechanism or approach. So thanks for joining us today. I thought we'd start off really kind of in the category of what I view as inflammation, starting off with the Lp(a) category, where we have a couple of products that are percolating along in phase 3, and then a lot of others that are in earlier development. So Novartis has pelacarsen, Amgen has olpasiran, and we should be getting some data fairly soon, meaning in early 26. So I guess I look at Lp(a), presumed causal risk factor for cardiovascular disease. We don't really have proof that pharmacologic intervention actually leads to CV benefit. So I'm just going to cut to the chase. Do you guys think these drugs are going to work when we get the phase 3 results?
I'll start. So Lp(a) is common, is a strong signal for residual cardiovascular disease risks, and at least the human genetic studies strongly supported as a causal biomarker, pretty much as strong as anything else, including traditional risk factors. So I expect that the clinical trials should be positive. At least the medicines showed robust lowering of Lp(a) and lower cardiovascular disease risk. The current trials suggest that they're pretty favorable as far as side effect profiles. That's one way that obviously it could be thrown off. A key aspect will be patient selection. Those who benefit the most will have the highest Lp(a) level. So, we'll see what the overall effect is, but I imagine it'll be different across values. And, obviously the industry has caught on to this. That's why there are lots of medicines in development.
So I have a slightly more sanguine approach, I think, to the causality argument. I think most Mendelian randomization is flawed because the causal chain assumes there's no other mechanism by which Lp(a) or any other biomarker in this type of Mendelian randomization strategy could possibly work, and we know already there are multiple ways in which Lp(a) could work. On the other hand, I also take a very empiric view of the human data, which is I think there's still a really good chance that the drugs will have effect because, exactly as Pradeep says, they definitely identify a group of individuals who are at increased residual risk. I think the target populations are going to be quite nuanced in the long run, but my gut is that there will be a subset of individuals who will benefit from lowering of Lp(a).
And I guess I'm falling in line with Pradeep, and that I'm pretty optimistic about the chances of these being beneficial just based on the epidemiology, the Mendelian randomization studies, and generally the risk profile of people being enrolled in these studies.
Yeah, I think, there are sort of three questions wrapped up in this. One is the biology. If you could reduce LPA levels by some mechanism, would that have a causal impact on events? Second, does the drug that you're using in your experiment actually do that in a way that doesn't have some other effect that offsets it or something? And then third, did you design an experiment that allows the drug to actually have that effect in the population you intended to study? And so whether these trials are ultimately positive takes all of those into account. I think it's a compelling hypothesis for the reasons stated and appears the right population. So my guess is that the trials would be positive.
There's different mechanistic approaches when I look at the various products in development. We have antisense oligonucleotides, we have siRNA, we have Lilly now with an oral small molecule. They're in phase 3 as well. Is there any a priori reason to think it matters how you knock down Lp(a)?
I mean, I personally don't think there's any evidence that any of the different mechanisms will necessarily have any more or less effect on outcomes. I do think the biology is quite distinct, and it's certainly conceivable from what we know about residual ApoA that there might be effects on insulin resistance, there might be effects on thromboembolism, but the reality is I don't think we fully understand the biology well enough to even be able to make those guesses. And it's one of the reasons that clinical trials are such a powerful tool. I think human experiments end up being really the rigorous way to test these hypotheses, and I think we're going to see it in the results of these trials.
Certainly among the drugs that are preventing the translation of the protein, I wouldn't expect there to be a difference. Now, if what you're doing is preventing assembly or somehow breaking it up some other way, you could imagine, but I don't think there's an a priori reason to assume that's going to translate into a clinical difference.
Lilly's product is unique in that it's oral. It also mechanistically works a little bit different because it blocks the assembly of apo(a) and lipids. And as a consequence, it does raise circulating free ApoA, and I think there's been some theoretical concern in the literature, but what that might lead to. In as much as you're familiar with mivaloplan, any thoughts on that?
Yeah, I'll say that, I mean, as you highlight, Tim, nobody really knows. So mivaloplan basically dissociates ApoA, the key distinguishing factor of Lp(a) from ApoB, the central molecule kind of enabling the assembly of lipoprotein a. With that dissociation, obviously you're not able to assemble Lp(a), but you have free associating ApoA. That phenomenon is not well described, naturally. That doesn't occur because generally ApoA is just covalently bound to ApoB, creating an LPA molecule. We know that the gene LPA, which encodes ApoA, arose as a gene duplication event from plasminogen. And it happened really late in the history of life. It is only in old world primates and in humans. And it has homology with fibrin, so it's with plasminogen, so you can imagine it somehow interfering with fibrin, potentially having a role in hemostasis. Nobody really knows. I mean, even if you just look at the LPA biomarker epidemiologically with cardiovascular disease risk, it's not like LDL cholesterol, this monotonic association with coronary artery disease. If you do splines or whatever, if you look at not just a single slope, you'll see it kind of go down within the normal range, lower cardiovascular disease risk at higher values. And then when you hit, 50, 75 nanomoles per liter, it kind of goes up. So whether ApoA will have a role in potentially adverse effects in its free-floating state is still an outstanding question. It's really hard to study because, as I said, you only see this phenomenon of Lp(a) in old world primates and in humans, and they're transgenic models, but it doesn't recapitulate the full biology. I think we're only going to be able to see this in the clinical trials.
Minimum level of risk to be viewed as clinically significant?
You mean the risk reduction?
Yes, risk reduction on the MACE endpoint.
Yeah, I think this is always a question, isn't it? I mean, so much of it depends on how the trials play out. If there's a salutary effect, I think you can often see very rapid uptake. I would anticipate the effect, given the fact that these individuals are all going to be already on multiple different disease-modifying therapies. You'll have to pick a very nuanced subset to be able to see a really large effect size. But on the other hand, in that subset, if it does have an effect, it may end up being a very powerful tool and therefore being adapted early. I'm sort of hedging to some extent, but I think you're going to need to see 20% plus effects for anybody to really notice, especially for anybody to pay additionally on top of existing therapies. And that obviously means you have to resolve the heterogeneity very, very well in order to find those highest risk individuals.
I mean, the human genetics have tried to answer this by just basically comparing the slope of the genetic association of LDL cholesterol and coronary disease and then comparing it to the clinical trials, and then making the assumption that Lp(a) would be the same. And those estimates have varied between 50 to 80 milligrams per deciliter lowering. That's a substantive amount of lowering. But that's not like a validated approach for anything beyond LDL cholesterol. So we don't know, but the effect estimate for Lp(a) in coronary artery disease is not the same as LDL cholesterol. So one, you will need potent lowering, the medicines obviously do, but the selection of the patients will be critical. Like really, I think those larger effect estimates you're only going to see with much higher levels. My prediction is that we'll see an overall smaller average relative effect, I think maybe 10%, 15%. However, it would be really important to look at the different ranges and really identify the folks who are going to benefit the most.
And I guess a caveat, if you're looking for what's your benefit, it somewhat depends on what the risk is, right? We said we don't think that there's any significant risk so far that we've seen safety signals, but I think in general, a lot of us are looking for 15, 20%. I know the trials are powered for that based on the starting Lp(a) and the best estimates we have about how that might translate to benefit. So I think that's the goal, is the 15 to 20% based on a really high initial baseline Lp(a) in these patient populations.
And I think that there's sort of a biology question, which is, I agree, that's sort of what people are anticipating, and I think you would be sort of disappointed with the biology if there were only, say, a 10% reduction. However, the clinical importance might be different than some other lipid-lowering therapies. So if all you're doing is targeting LDL, there are a number of therapies, and you only reduce risk by 10% in a reasonable population, that would certainly be seen as a failure. Here you have a group of patients without other directed therapies. You might be willing to tolerate a lower relative risk reduction in that setting.
Okay, so staying, one last question under this category of inflammation, and it might sound like an oddball question. It's the GLP-1s in cardiovascular event reduction, where we've seen now 2 trials with the contemporary obesity drugs, SELECT with Wegovy, more recently SURPASS CVOT with the Lilly drug. And when you look at the mediation analyses, at least for the first trial, it showed that it wasn't necessarily weight loss driving that benefit. And I think there's been discussion about, pleiotropic effects or anti-inflammatory effects of the GLP-1s. So any perspective on that aspect in terms of what's driving benefit if it's not weight loss? We know that other things like A1C reduction also play a role, but is there kind of direct anti-inflammatory properties that are on the radar of folks like you?
Yeah, I mean, I think this is everybody's trying to figure this out. Nobody really has an answer for what exactly the mechanism of benefit is. I think, there's improvement in multiple cardiometabolic parameters, and we sort of think that maybe the benefits are multifactorial in that way, that there is weight loss, but of course there appears to be lots of weight loss independent benefit that we're seeing. As you alluded to, that mediation analysis suggested that, and I think we've seen that in the diabetes trials. When we look at the magnitude of weight loss and the benefit, they don't always correlate. There's lipid improvements, there's, as you point out, inflammatory improvements, but it's really quite hard to understand and to know exactly what is if there is one thing, and I don't think there is one thing. There's also the sort of question about whether it's not necessarily mediated wholly by these cardiometabolic risk factors, but also by some direct effect of targeting the GLP receptors. That's possible too. So I think everybody wants to know the answer. I don't know that we have the answer to that. That's my 2 cents.
Tim, I'll add that there is actually one GLP receptor agonist that was evaluated in clinical trials, never made it to market, albuglutide, that was developed by Pfizer. And that was an interesting medicine because it improved diabetes control, didn't lead to weight loss, but in a trial population of diabetics actually reduced cardiovascular disease outcomes. For me, that's the strongest evidence that suggests that there may be other weight-independent effects.
Great. Okay, I want to shift to a different topic, which is the lipid space. And fewer questions in this section. So oral PCSK9s, we've got a couple of in development, one that will likely launch next year, which is Merck's product. It's a peptide, and then AstraZeneca has one, and that one's actually a true small molecule. So I guess it's more of a commercial question, but will an oral PCSK9 be something that you would envision there's substantial embrace of? And what do you think that does to the injectable products? The most recent of which is, an every 6-month injection, which isn't hard to take. That's Novartis's drug, Leqvio.
I mean, my attitude is, at least on the implementation side, that at the end of the day, I think, a few years ago, we would have thought anybody would do anything to avoid an injectable, and now we realize that people are very comfortable with an injectable if it's effective. I think the key is trying to understand whether anybody could compete with a twice-a-year injectable, just in terms of convenience. And you're seeing that even with statins, which are generic. So I'm not certain how an oral PCSK9 will play, but I'm sure there'll be a niche in which it will eventually end up resting. But I suspect a lot of what happens between then and now in terms of capturing the injectable market is going to be part of the equation.
Uptake's obviously been slow, and so there's clearly a need. There's a place to be filled, and it seems an oral medication could easily do that, and so I think there's reason to believe that the uptake could be brisk, and there's a large group of people who stand to benefit. As Callum was saying, I think people are becoming more accustomed to injectables. It's every 6 months for the siRNA. You could imagine a scenario where those two lines cross eventually, but at the moment, there does seem to be a large need.
Great. Okay, so next mechanism under lipids is CETP inhibitors. So they're still alive. Lengthy history with lots of companies in the past that had them: Pfizer, Merck, Roche, Lilly. 80,000 patients across the trials with those 4 compounds. All of them failed for one reason or another. We have obicetrapib, which is in phase 3. And I guess the question is, why might it be different this time around? I know there's been a shift in thinking away from what CETP does and maybe where the benefit's coming from. When I listen to the messaging behind obicetrapib, now it's all about LDL. We're no longer talking about raising HDL. But what's your perspective on this program?
Well, I mean, so one, I am glad that somebody's still investigating CETP. There's actually still a very strong human genetic signal at the CETP locus for coronary artery disease risk. The proportional relationship, though, is related to HDL cholesterol. The challenge is then translating that pharmacology and then administering in the right patient group. All the CETP inhibitor trials have generally been in patients with lower HDL cholesterol. So there, you're probably raising potentially HDL cholesterol that may not be the kind of HDL cholesterol that could be maximally functional. The biology here is basically shifting cholesterol and cholesterol esters between HDL and LDL. That can also lead to substantial lowering for LDL cholesterol. Because the biology, at least pharmacologically, is most robust with LDL cholesterol, I understand why there is a focus on obicetrapib, because that's more likely to be beneficial because it's lowering LDL cholesterol. But I don't know if that's fully recapitulating what the true biology is at that area. That's one. But number two, we just talked about some of the challenges of kind of getting into an increasingly crowded market for LDL cholesterol, and there will be a lot of nuance in trying to think about what its role will be.
So I think, this hypothesis of if you lower LDL and ApoB by that mechanism and maybe with some LPA effect, as is true here, do you impact cardiovascular events the same way you do by lowering LDL with some other therapy like a statin or a PCSK9 inhibitor? That's not fully known. Pointing in the direction that that's reasonable is the fact that anacetrapib had a cardiovascular effect in line with its LDL lowering. So I think that leads me to believe that you could anticipate a cardiovascular event reduction in line with the effects on the things we know matter, like LDL. Obviously, we need to see, but it's reasonable.
And I totally agree. And to add on to that too, I mean, with obicetrapib, it's a more robust LDL reduction, and then also, a fairly generous reduction in Lp(a) too, which of course we've talked about. We don't know exactly how that's going to translate to outcomes, and it's not on the magnitude of the targeted therapies, but is interesting that this agent is a little bit different than the other ones that were out there.
Yeah, I think I would agree with everything that's been said. I think there are two sort of basic premises. One is the mechanism itself the cause of the adverse events? And I think, that's something that is not entirely clear. I think the biology is much more complicated. I mean, all of the apolipoproteins we treat as if they're just literally markers for particles. They all have their own signaling attributes. They're all doing 100 things in the biology of the human. So I think we just have to be a little bit wary of it. But ultimately, the trial will tell us. I think just as a point of reference, there are many trials of LDL lowering where the net outcome was not actually a survival or an event benefit. But fibrates are a great example. And we, I think, forget there were 9 positive LDL lowering trials with fibrate, but not one of them actually changed the net outcome. So this is a history that goes back a long way, that it's not a perfect representative of what the biology is. And I think we just have to be careful. And again, another reason why the trials will tell us.
Great. Tazeen, you wanted to ask some questions?
Sure. Maybe to change topics to another area. So we've talked about several patient groups over the last few minutes, but I wanted to spend a few maybe on cardiomyopathy. So ATTR-CM, I think historically it was viewed as a bit of a smaller or smallish indication, but I'd like to get all of your thoughts, if I may, on how small do you think this indication is, or maybe to put it differently, how underdiagnosed do you think this condition is? And how has the introduction of tafamidis over the last several years impacted the number of patients that you're seeing in your respective practices?
So, I think it is definitely underdiagnosed quite substantially. I think the biggest impact, as with almost any disease, is once you have some form of therapy, you do strive much harder to identify the subsets. I think, the pretty good data, it's about 15 to 20% of HFpEF. It's probably in a smaller percentage, although non-ATTR amyloids are definitely contributing to HFrEF. And I think what you're starting to see is actually that imaging has been the main driver of the increased diagnosis. And one of the things that is definitely clear is that we are identifying many more patients than get substantial benefit with the current therapies as they're being deployed. And some of that is who is eligible for them, some of it is the cost, and some of it is just the funneling of patients into the therapeutic pathways. And so I think there's a lot of room to improve how we diagnose, particularly if we diagnose much earlier, because that's the point at which, at least from all of the experimental data we have to date, therapy will have the greatest impact. But even at the moment, I think we're seeing real benefit from the use of tafamidis, laying the groundwork for the introduction of the emerging agents.
Just to add, I agree with everything that Callum said. It is being increasingly diagnosed, still heavily underdiagnosed. I think most of the increasing diagnosis often is happening at later stages, which is less of an opportunity for benefit patients that are currently coming into the hospital. I think increasingly I'm excited about the increased vigilance and awareness about trying to identify at earlier stages, and that's increasingly happening. And a lot of this is spurred by, first, the introduction of tafamidis.
Okay, so given that there's now 2 stabilizers and now a new silencer, can you just overall talk about, let's say, the differences that you're seeing between tafamidis and Attruby, and then we can talk separately about Amvuttra?
Yeah, I don't think there's really a definitive set of objectively defined differences between the therapies at the moment, because they've all been used in slightly different settings, some in the context of the original outcomes data came from a neuropathy trial. So I think finding the balance in how these agents are going to be used is challenging, partly because of the fact that we don't have a really good sense of the spectrum of early disease, and partly because of the fact that intervention, exactly as Pradeep said, has been largely focused on really quite late-stage disease. I think as people are bringing these new interventions to the clinic, they are radically resolving some of the heterogeneities in the underlying disease, and I think you're going to see significant differences in how the drugs are used individually, and importantly, how they're used in combination, emerging over the next 3 to 5 years. I think the efficacy of the single agents is certainly not at the level that any single agent looks like it's going to be the winner. And so I think you're already starting to see off-label use of different drugs in combination in an effort to try and understand if you inhibit SEED, if you stabilize, if you completely eliminate or dramatically reduce TTR production, how does that impact the net outcome on, essentially, on myocardial disease? And I think people are now really focusing on that in a systematic way, but it's still not in any of the existing clinical trial designs.
Yeah, I mean, as you know, no head-to-head trials. The Helios-B trial, which evaluated vutrisiran, allowed it for background tafamidis, and in the subgroup analyses, it looked like it was additive with the two, so that's reassuring that there could be a rationale for combo therapy. I think, especially with the silencers, there's increased recognition that you need to identify, you need to diagnose much earlier. So as those permeate market, I'm hopeful that we'll see more earlier diagnosis of TTR amyloid.
And I think there are several efforts at the moment designed to try and understand the diathesis leading to amyloidogenesis. I mean, part of the reason the diagnosis is so difficult is there's a substantial proportion of the population who are at risk and have some degree of amyloidogenesis, but never leads to pathological outcomes. And I think matching those treatments to the stage of the diathesis, understanding the diathesis better, be able to even measure it, is, I think, a convergence between the inflammatory fields and the amyloid fields that we're starting to see happen in real time.
So you mentioned the off-label use of combination therapies. So do you think that's what ultimately physicians will gravitate to over time, as long as these options remain, static and there's not something better that comes along?
I mean, you'd like to believe it would be based on empiric data. I think one of the things, and we've talked about it multiple times this morning, is the difficulty with modern medical cardiometabolic therapy is there are actually quite a lot of successful agents in the field at the moment. And there's not really, exactly as Pradeep just mentioned, there aren't really great examples of head-to-heads or changing the order of introduction or eliminating some drugs and adding others up front, even in standard GDMT and traditional HFrEF. It's almost an indictment of the way that we do trials, that it's 40 years after beta blockers are introduced that we realize they don't really do anything in post-MI, and that ends up being a formal trial. So we need to build much better systems that actually allow us to test things really in the real world in an A/B testing mode, and I think you're going to see that. So I don't think people will be doing it randomly. I think you're already starting to see networks emerge that are looking at combination therapies, not just in amyloid, but in all forms of lipid-lowering, inflammation, heart failure, where people are starting to really start to randomize in the record and understand in a real-world setting what's the minimal set of drugs that you actually need in order to get the real risk reduction you're looking for. And payers are obviously very interested in this as well.
Yeah, I'll add, I mean, there's a third class that's coming, right? The clearance medicines through monoclonal antibodies. So, how are clinicians going to decide? We really need the clinical trials. My suspicion is that not every single patient is going to need every single medicine, but we would need the trials to help us identify who would need one or multiple.
For the future of using combo therapies, do you think it's necessary, just given the cost, let's say, of CM therapies, do you think it's going to be necessary to have head-to-head studies or combo studies specifically in order to be able to increase the use in patients beyond, a few, maybe it's more than a few, you can clarify that, off-label with getting reimbursed?
Yeah, I mean, combo therapy makes it increasingly less potentially cost-effective. I think the key, as Callum put earlier, is really identifying the patients who are going to have complications from TTR amyloid. We're making, and obviously there's a high rate of them that will transition over to heart failure, but I think but it's not all of them. But if we can better identify those patients, then I think that's when the cost perspective for multiple medicines might make sense. So I think there's still some basic work that would need to be done.
Totally agree with what Pradeep said. I think you want to also add in the fact that just even the kinetics of the biology are so poorly understood that thinking about how you might use the combination therapies based on what we know already about amyloidogenesis would be a shot in the dark. So I do think, exactly as Pradeep said, you're going to have to see some combination trials, just even across stages of disease in order to really understand how you're going to use them.
And timing will be key too. I think, as there's earlier diagnosis, there are also pretty good AI ECG tools to help us identify much earlier stage disease for TTR amyloid. Should all of them be on combo therapy? My suspicion is that, not all of them should be or need to be, but maybe identifying the time points as well. There's still much more that needs to be done, but that group of patients is going to be increasingly expanding.
Okay, thank you.
Okay, so I wanted to move on to a couple different categories, starting off in the novel anticoagulant space with orals. The factor 11s, so we've got 2 in phase 3. These are intended to be replacement for the factor 10s, products like Eliquis. And we've got data that should be coming out right around year end from the first phase 3 trial, at least in a stroke setting. We had, I think, kind of mixed experience thus far with clinical development programs. We've had some companies drop out. We have others that are still in the mix. Current thinking of the class, I guess, like the LP-A's, are these going to work? Just cutting to the chase.
Sort of the fundamental human condition is wanting something for nothing, and this is one manifestation of that, I guess. These drugs are all quite different in terms of how they're acting and also whether they have earlier phase or different setting data to actually show that the drug is doing something. For example, reducing the risk of DVT or not. And so I think it's quite important not to assume a class effect across these agents. And then also the clinical settings are very different. So secondary stroke prevention versus atrial fibrillation, and then of course the comparator. Is it against an oral anticoagulant? Is it against no therapy in a high-risk population? So these cross-trial comparisons are going to be very difficult, but I think we should anticipate that these drugs are different across this class.
And I think the context matters, right? I mean, as you heard from Brian, VTE, there's evidence of benefit. This is where 11A has more of a role in the intrinsic pathway, and also in other settings where there is prostheses and there's contact, whereas 10A is much more in the extrinsic pathway, where tissue factor is required, much more of a role in stasis and atrial fibrillation, and that biology seems to translate to what we're seeing in clinical trials.
So we've got 2 different settings here where phase 3s are running, one being secondary stroke, which is on the arterial side, and you're looking at these drugs on top of either single or dual antiplatelet therapy. And then you've got AFib studies, which are more on the venous side, where you're trying to bump out something like apixaban. Anything about that that would suggest to you one of those settings is more likely to hit than the other? Or is it just not knowable?
So the risk of bleeding seems to clearly be very low. And so I think a scenario in which this drug is favorable is going to be one in which there is some demonstrated efficacy for reducing whatever type of event we're studying, presumably in a group of patients who are at high risk of bleeding. Obviously, the oral anticoagulants are quite good. They're not perfect, but they're quite good. So it's a high bar to meet, but there are clinical scenarios where the bleeding is really the major issue. And if you can demonstrate a quantifiable reduction in whatever type of event you're looking for, I think there are patients in which that would make sense.
Okay, let's move on to the last category, which is in hypertension. A new class of drugs on the horizon, aldosterone synthase inhibitors, 2 products. Astra has baxdrostat, and then a small company, Mineros, has lorundrostat. It's data where we've seen the phase 3 results in 2025, and to me the data look fairly similar to each other. So I guess the question for you is this the next big thing in hypertension? And is the data compelling enough to bump out the old standard product spironolactone, which is what they're really going after?
Hypertension is the most common risk factor in the world, and including in the US. Much of that is often related to the multiple different medicines and the side effects that patients have with medicines. There can be, I would argue, the tools that are already available for many of the patients, so just getting them onto them and then figuring out the various different barriers for them to actually taking the medicines. I will say the aldosterone synthase inhibitors do help as far as they have a favorable side effect profile and they're reasonably potent. So I do think that they can make a substantial impact, and that at least the two medicines that have been studied so far have similar efficacy, roughly about 9 to 10 milligrams per mercury lowering for systolic blood pressure. So I think it will be helpful, but hypertension is very complicated. Just adding another pill may not immediately solve the solution of hypertension.
Yeah, I would agree with Pradeep. I think it's a complicated space. I think the real question from my standpoint is, will this class of drugs have a role in heart failure, actually? I think is, from my standpoint, going to be the most important question, because that's usually what drives changes in the hypertension space in the long run. The fundamental difficulty, I think, is the class is pretty similar to MRAs in general. So you are literally just changing a side effect profile at the moment in terms of what we know about the drugs, but in the long run there may be some more salutary benefits from this particular class, partly because of the fact that they're operating upstream.
You know, but to Pradeep's point, I do agree that having options available with a better side effect profile for, you know, treating hypertension is great. I think it is an advancement. So I think it's a positive step forward. Sure.
I'm not sure if you saw the data, but at ESC, the ASTRA data set showed that when you took patients off therapy on a randomized withdrawal study, you actually had a persistence of effect. Is that real, and is that meaningful? And is that differentiated from other hypertension drug classes?
I mean, it's exciting. It extends beyond the half-life of the medicine. You know, whether it's true disease-modifying therapy as opposed to chance or maybe some persistent effect definitely requires a longer range study to really look. And then I would say I would be really interested in other surrogate outcomes. Is there still suppression of aldosterone? Is there a change in albuminuria? What's the kidney function doing? But this could be an important differentiator that should be studied.
Yeah, there are pretty good data even from the original spironolactone studies that you do see a lag, you see a reset in the aldosterone pathway after manipulating it even downstream of the receptor. Whether that's what you're seeing here is just the reset, or whether it's actually a means of identifying a subset of people who actually do have some comprehensive downstream and longer-term sustained effect is still open to debate. And I think, as Pradeep said, you're going to need much longer studies, much more detailed mechanistic evaluation to truly understand it.
Yeah, it sort of struck me as intriguing that way, biologically. Practically, I mean, whatever, they're going to be taking the medicine, so who cares? I mean, you're not going to just stop it, so not sure what the implications are. But
I mean, I suppose if somebody doesn't have perfect compliance, then that gives you some more sort of even effect in a way, yeah.
So in what % of patients do you run into problems with spironolactone when you prescribe it, such that when you have these out, you might fully walk from spironolactone? Because payers, from a commercial perspective, are, you know, I don't know if they'll force docs to use spironolactone first or not, but I don't think spironolactone fails in everybody. I think it works in a reasonable, you know, what % of patients does it actually, is it tolerated well enough that you can use it?
I mean, in my experience, about 50% of all male patients complain about gynecomastia. And so if there was an alternative that you could replace, and actually that personal experience is supported by the data, and even if they don't complain of overt gynecomastia, they complain of mastalgia or similar symptoms. Women, on the other hand, they have a higher rate of spironolactone-sensitive hypertension. Their aldosterone axis is typically more important in their underlying hypertension. So I think you're going to see a lot of people, a lot of men trading it for spironolactone pretty quickly if they have been shown to be, if they've been shown to respond to the addition of manipulation of the mineralocorticoid axis. I think in women it may be more difficult, but there may be other secondary effects that are also useful in women. And theoretically, there are definitely some effects in polycystic ovarian disease where the proximal synthase inhibitors may have additional benefit. But none of that has been shown so far, but there are theoretical reasons to support it. So I think you may end up, if people stratify hypertension carefully enough, if people are looking in a comprehensive way at the symptom profiles, I think you may see some real uptake.
Great. Well, we are out of time. So Callum and Pradeep, Aaron and Brian, thanks so much. It's been a fascinating discussion. And thanks for everyone for attending our morning session.
Thank you.
Thanks.